Hi, PE 111 class. I'm coming to you from my son's bedroom, as this is the quietest room in the house right now. And today we're going to go over Chapter 17, which involves the wrist, hand, and finger pathologies. Hopefully by now we know that we're going to go into a little bit of the clinical anatomy, functional anatomy, evaluation, and then some special tests. And as far as injuries, hopefully you're coming across or thinking that there's potentially room for a fracture, dislocation, sprain, strain. You've probably heard of carpal tunnel syndrome and then also a jammed finger. And this is from right after Steph Curry broke his hand about 4 months ago.
I literally just found out 5 minutes ago. So it's we'll meet tomorrow as a staff. We'll watch film with the team, and we'll be able to discuss all that stuff. But we've obviously it's been a tough start for us on many levels. So we're just trying to find our footing, and obviously this puts us in a tough spot. So we'll assess it and we'll go from there.
Were you able to talk to Steph?
All right, and get into the clinical anatomy. So specifically first we're going to look at the bony anatomy, and we've already gone over the last lecture, the elbow and forearm. So now we're specifically looking at wrist, hand, and finger. So in this picture you can see the distal portion of the ulna and the distal portion of the radius. And those two articulate with the carpal bones. There are 8 carpal bones, and we'll go into those in the next slide. And then the long bones that make up your hand, or kind of the palm of your hand, would be the metacarpals. And then your fingers are also known as phalanges. So, looking specifically at those carpal bones, I don't know if you guys remember in 108 that I spoke a little bit about an acronym. And with those carpal bones, we're going to start on the thumb side, more proximal, and I have it set out down here. SLTP stands for some lovers try positions, and TTCH, that they can't handle. The thing that's unfortunate is there are 3 T's, so you'll have to kind of differentiate which one between which. But specifically looking at the scaphoid, the lunate, triquetrum, and pisiform. Pisiform, remember now, is going to be more on your pinky side, and then you're going to go back over to the thumb side. Trapezium, trapezoid, 5, 6, capitate, 7, and then the last one is hamate. Okay, so hopefully that will help you a little bit be able to identify those different bones in the wrist. Okay, articulations and where the ligaments attach. Okay. So with this, we're looking specifically at the distal radial ulnar joint. Okay, so that's the very end of the radius and the ulna, and right there you can pronate and supinate. Then on the radial side, where the radius connects to those carpal bones, you've got the radiocarpal joint. In between each of those carpal bones, you have intercarpal joints. And between the carpals and the metatarsals, you have the midcarpal joints. Okay. In between the phalanges, we've talked at length before, similar to the toes. The fingers also are phalanges. The thumb only has 2 phalanges, where it's the proximal and the distal phalange, and there's only 1 interphalangeal joint. And then on digits 2 through 5, there are 2 interphalangeal joints, because you've got a proximal, middle, and distal phalange. So that first joint would be the PIP joint, the proximal interphalangeal joint, and then now towards the nail bed, that joint would be the DIP, or the distal interphalangeal joint. Okay, and looking at all of this, there are a ton of ligaments that attach the bone to bone. So when you have a different type of force coming onto the hand or wrist, it runs the risk of potentially stretching those ligaments and potentially spraining those ligaments. So you have a ton of ligaments that can and do get sprained within the wrist, and or even when, say, you're playing basketball or volleyball and end up jamming your finger, the collateral ligaments on your fingers also get sprained, or as we kind of call it, jammed. So looking at the TFCC, which is triangular fibrocartilage complex, when we're looking at, again, remember, if we're standing in anatomical position, the ulna is on the medial side. So you're looking at that medial aspect on this. If you happen to foosh, fall an outstretched hand, a lot of times it can damage this medial aspect and cause a lot of pain. Looking further on here, I want to note that the scaphoid is probably one of the most common fractured carpal bones. It's commonly fractured, but the lunate is the one that's most commonly dislocated. Some of the things about the scaphoid fracture, about 70% of wrist fractures involve the scaphoid. It is more common in people ages 15 to 30, and it has a high incidence of non-union fractures. So what's going on with that is there is blood flow that goes to or through the scaphoid, and if that is damaged, it ends up or could result in a non-union fracture, meaning they would have to go in and surgically fix it to help it heal. Okay, the nerves. So this is a transverse section of the wrist. You've got some of the carpal bones right in here. The nerves are the yellow that go through here, and you've got the median nerve that's right here in that within that flexor retinaculum. You've got the ulnar artery and nerve on that medial aspect, and then over here, this red would be the radial, where we're taking that radial pulse. Okay, looking a little bit further into specifically the radius and ulna. Okay. The transverse carpal is the ligament that forms the roof of the carpal tunnel. You guys probably have heard of people with carpal tunnel when you don't have an ergonomically correct workstation. Maybe you're on a keyboard and don't have a wrist pad. That can definitely affect pinching that within that carpal tunnel and causing that numbness and tingling down to the distal fingers. Okay, so on each of these, we've got smaller intrinsic muscles closer towards the bone. On here specifically, let me see if I have my drawing. We've got the abductor digiti minimi muscle, the flexor digiti minimi brevis, just deeper than that. Over on the thumb side, we've got our abductor pollicis brevis and opens pollicis muscle. And similar thing, when we're looking for each of the different body parts, we're still going to go through either our SOAP or our HOPS, which specifically in here we're asking about history. So have they ever had pain in their wrist or hand before? Anything that caused them to lose function? Maybe they were in a cast and it was immobilized. Have they been diagnosed with rheumatoid arthritis? I have had a couple of patients before that had juvenile arthritis. So they were born with that. And then also Raynaud phenomenon. So with that, I believe I've shown pictures. Those of you that are in the 140 series, on our group me, I think 3 or 4 weeks ago, I sent a picture of somebody's hand where the hand was regular color and the fingers were really white. And that is an outward telltale sign of Raynaud's phenomenon, where the distal extremity, specifically the toes and fingers, don't get as much circulation as everything else. And then also it's important to know what the present condition history is. When did it start? Are you right hand dominant, left hand dominant? Are you doing things differently than you normally would have? Maybe before you were always pen and paper writing, and now because of this quarantine, we're inside and now you're doing more typewriter or keyboard activities. So you might start having a little bit of slight pain during that. All right, and this is just a video that I want to show you guys, so bear with me for about 8 minutes or so on how we're going to evaluate a hand.
So the next exam that we're going to do in our series is the hand and wrist. And again, we just want to start by looking for observation and just looking for areas of swelling, bruising, abrasions, etc. And
so we're looking bilateral. Make a mental note whether it's their dominant hand or non-dominant, but it should be pretty apparent. Look for discoloration, swelling, any type of deformities. Also look for any type of scarring. There are things, and unfortunately I have come across some of my patients who had eating disorders. Okay, so with that, you guys have probably heard of bulimia, where a patient would gorge and then potentially make themselves throw up in order to, I guess, alleviate all those calories that they have eaten. One of those things that we're looking for is Russell's sign, and it's one of the few outward signs of bulimia, where there might be small cuts or abrasions over the dorsal surface of the metacarpal phalangeal or interphalangeal joints. And what that's doing is from the patient being able to stick their finger down their throat far enough, and those abrasions are actually abrasions from their incisors and from their teeth.
So you just look at both sides of the wrist, and you can often sometimes see if there's swelling in the area of the scaphoid or swelling in the area of the triangular fibrocartilaginous complex, which sits down here at the end of the ulna. Or in the hypothenar or the thenar eminence of the little finger or the thumb. Then once we've done inspection, we'll have the patient do active range of motion. So we'll have them extend the wrist as far back and see if that causes pain or has equal range of motion compared to the other wrist. And then wrist flexion downward, and then ulnar or radial and ulnar deviation. And then the hand is already in a pronated position, so we'll have them supinate the wrist and then pronate the wrist to check for full range of motion in anything that causes pain. Then we can do the same thing with strength testing in all of those ranges of motion and have them do it against resistance. So extension against resistance, flexion against resistance, have them make a fist and do ulnar deviation against resistance, radial deviation against resistance. Then you can shake their hand and have them do a pronation against resistance, supination against resistance, and then you can have them squeeze your fingers and see if where and if they get pain with those activities. The next thing that we can have them do, or we can do, is palpation. And the wrist has a lot of bones in a small area, and so you can't often palpate specifically every bone, but some of them are easier than others. So usually I'll start by feeling along the ulna, and sometimes you can feel the extensor carpi ulnaris tendon and the flexor carpi ulnaris tendons, as well as just distal to the ulna you have the TFCC, triangular fibrocartilaginous complex, which acts like a meniscus of the wrist. Then you can get the radial ulnar joint, the area between the radius, the ulna. Then you can palpate, there's a hole that is in the area of the lunate bone, and if you extend the wrist, there's a divot, and if you flex the wrist, that divot goes away. So then you know you're over the lunate bone. Then you have the scapholunate ligament, and then if you have them extend their thumb, you'll see
We are being censored.
then you know you're over the lunate bone. Then you have the scapholunate ligament, and then if you have them extend their thumb, you'll see where we have the lines here of the extensor pollicis longus and brevis. The space in between that divot is the snuff box, and that is where the scaphoid sits. So you can palpate the scaphoid there. You can palpate along the tendons. There's one more tendon over here, the abductor pollicis. And if you turn the wrist over, you can find the pisiform bone. And then if you come about 1 centimeter or 2 centimeters towards the index finger, from the pisiform bone, you'll find the hook of the hamate, which is often broken in racket sports. And then coming off of that, you have the ligaments that come over to the scaphoid and form the carpal tunnel. And if you tap on that area, that's called a Tunnell's test, seeing if they get any paresthesias into their thumb, index, ring, middle or ring fingers. You can then have them start doing some special tests, looking at the metacarpal joint of the thumb, which is the most prominent joint here, and that's the most common place to get arthritis in the hand. And so you can palpate that area and then grab their thumb and grind it in a circumduction fashion to see if that causes pain to that area. You can then have them extend their thumb and palpate again along those tendons that make up the first dorsal compartment of the wrist, the abductor and the extensor pollicis brevis, and then you have them put the thumb into a fist position and ulnar deviate. That's called Finkelstein's test, and that diagnoses inflammation of these two tendons, which make up the first dorsal compartment, and that's called De Quervain's tenosynovitis. The next thing that we can do is look at the MCP joint of the thumb, metacarpal phalangeal joint, and look at the ulnar collateral ligament, which is probably the most important ligament of the hand and wrist. And if you grab the metacarpal and grab the phalanx and do an abduction maneuver, you can stress the ulnar collateral ligament and see if that is loose compared to the other side or if it causes pain. Then we'll often move down to the fingers and have them do range of motion of the MCP joint, the PIP joint, and the DIP joint. And oftentimes we'll do that individually to make sure that they're not able to compensate in some way. And if they are not able to move those fully, there are different injuries. If you move the finger into this position, that's a boutonniere deformity where you've lost your central slip of the PIP joint and the finger will sit in that position. There's a mallet finger where the tip of the finger is bent down and cannot extend. That's because you've lost the central slips that come down and attach and extend the DIP joint. There's a jersey finger where you grab someone's jersey and they pull away and you pull off your distal flexor tendon, and those people will not be able to flex the distal phalanx. Then there's a swan neck deformity where the finger will look somewhat like that. And it's not a mallet finger, but what happens is you injure the volar plate of the PIP joint, so this joint hyperextends, and then this joint flexes because the tendons are only so long, in somewhat of a swan neck deformity. Once we've inspected for deformities of the fingers, we'll move back up the wrist and do some specific stress testing of different ligaments of the wrist. One is the radial ulnar shuck test. So you grab the radius, you grab the ulna, and you move them in opposite directions, stressing the ligaments that connect the radial ulnar joint. The next one is you put your middle finger on the pisiform bone, and you put your thumb on the ulna, and you push them in opposite directions. And that is the TFCC compression test. Another name for the radial ulnar shuck test is the piano key test. Now we've done observation, range of motion, palpation, and specific testing for strength and ligaments of the wrist and of the thumb, and that concludes our examination of the hand and wrist.
Thank you for bearing with me on that, you guys. That was the best video that I can find that wasn't extremely long and didn't get into too many individual specific what-ifs. So hopefully you got some good information out of that. So we've already talked about history and what questions we're going to ask, and that video showed us a little bit about inspection. First of all, we want to see their functionality of the wrist, hand, and fingers. Now, what if this patient is a water polo athlete or a tennis athlete? Where they're gripping either a smaller tennis racket or something as large as a water polo ball. Are they able to do that? Is that something that they were able to do before this injury even occurred? Have they had to alter how they are holding their racket just because of pain and pain tolerance? Also, general inspection. We're looking for any obvious deformities, malalignments, malocclusions. Look specifically with the wrist and hand, both in the patient's normal sports setting and then also just looking at the different range of motion. I know in the video it went over flexion and extension for the wrist with radial and ulnar deviation. We've already talked about supination, pronation. With the metacarpals and phalanges, really we're only doing flexion and extension. So that limits the special test and a little bit of what we're going on for inspection. If you come across a wrist like this, hopefully you can see that red arrow. That is a telltale sign of a ganglion cyst, which is just fluid buildup. Back in the day, we used to fix that by having the patient put their hand on a table or a desk and getting either an encyclopedia or a phone book. I know that shows how old I am. And slamming it on that ganglion cyst. Do not do that. We don't do that anymore. A lot of times that ganglion cyst can dissipate, or when they go in and see their MD or DO, they might be able to kind of help with that. So that's one of the types of cysts, and when you see it and palpate it, it's not stuck to any particular bone. It does move a little bit, so it's kind of interesting. So, if somebody in our class, and I think somebody in the 140 series does have that because we've talked about it a little bit. All right, a little bit further of examination, clinical examination. If you guys looking at the thumbs and fingers, if you guys have ever had an ingrown nail, whether it was a toenail or a fingernail, it's not very pleasant. And you can see over on this person, all right here, there's all kinds of fluid buildup. So one of the things that we would do, stereotypically it happens more often with toes than fingers, but it still does happen. What's going on there is the nail is kind of growing into the skin and causing some fluid buildup. Again, we would be using our gloves and PPE, make sure we've cleaned the area. A lot of times with that, what we actually do is stick a whole bunch of cotton up underneath the nail. So this nail's cut pretty short, but stick some cotton up under there. That way the nail will kind of grow up and out and hopefully alleviate that pain. Sometimes that nail is so short just because of how people cut it. Other times it's because of, biting on their nails. So something to think about. Also, when we're looking, there could be the sublingual hematoma. We talked about that with toes, where there might be kind of like a blood blister underneath the nail bed, and we can either use a cauterizer or lance the nail until we alleviate that pressure. Okay, so looking at how things articulate. So on here we've got number 1 and number 5 is the radius and ulna, and then over that has some of the other bones, specifically where they lie. It's a good idea when we're palpating and trying to identify each of the individual carpal bones, so we can have an idea of what is associated or affiliated with that up underneath. And this is a posterior look, and we're also looking at some of those tendons, the muscle that goes to the tendon that attaches to the different bones. Okay, this is getting really busy on here. So what I would like you guys to do is kind of pause this and take a look at the individual numbers and see where those numbers line up. Okay, specifically number 1, the thenar eminence, that's more on the thumb side as opposed to the hypothenar eminence that's on the pinky side. So I'll pause it right now to give you guys a chance to go back and look and differentiate what each of these individual things are. Okay, looking at the joint and muscle function. So with the wrist, we've got flexion and extension and radio and ulnar deviation. With the thumb, since, this is what makes us unique and having opposable thumbs to be able to write and whatnot, but the thumb can flex, extend, abduct, and adduct, and then almost circumduct. And then the finger is, all the fingers is really flexion and extension. So with each of those, first we want the patient to go through active range of motion, showing us that they can do it. Then we, as the clinicians, can perform passive range of motion. And if there's no hookups or anything like that, and the pain is not too great, then we can perform manual muscle tests and resistive range of motion. One of the other things we can do and determine is grip strength. So this is a grip dynamometer where it can assess grip strength. Obviously, your dominant side is going to be much stronger than the non-dominant side, but it's something to objectively measure and be able to identify. Hopefully you have some type of baseline to see what you want to get back to after an injury has occurred. Okay, joint stability testing. So at length, we've already talked about with the knee and now the elbow. So when we get into the wrist, hand, and fingers, when we're looking at those collateral ligaments, so just like on the knee, there's a medial and lateral collateral ligament of the fingers, we would do a valgus and or a varus stress test to be able to specifically look and identify when comparing bilateral if something has the same infill as a non-injured side. Okay, each of these individual ligaments that are stressed during passive range of motion, and it just depends on if you're in extension, flexion, radial deviation, or ulnar deviation. So that's something to kind of look at. I'll have you pause here for a second and just look at your hand and your wrist. Move your wrist into extension. Okay, so the primary ligaments that are stressed are going to be that palmar, ulnar, carpal, and radiocollateral ligament. And then secondary is going to be the palmar, radiocarpal, and ulnar collateral. go through now and do that with flexion, radial deviation, and ulnar deviation. And just like with the valgus varus, that's what we're doing right here with the radial-collateral and ulnar-collateral ligament stress test, where we're doing a valgus maneuver, where we're applying that lateral pressure and assessing the integrity of the ulnar-collateral ligament. And then the varus with the radial-collateral ligament. Same thing with valgus and varus for the PIP and DIP joints. And then the thumb metacarpal collateral joints. So when we're doing those, there is a UCL, ulnar collateral ligament of the thumb, and that's something that we see somewhat frequently in not only tennis, but think of hockey, sometimes baseball and softball when they're gripping the bat. They can and do get those UCL injuries with the thumb. Okay. So when I talked about the knee and the lower quarter screen, same thing with the shoulder, elbow, wrist, hand, fingers, there's an upper quarter screen. And the next time we meet, we will go over that. Remember I talked about myotomes, dermatomes, and reflexes, and then carpal tunnel syndrome and drop wrist syndrome. So that's something that we can do next time when we actually get to meet face to face, is the quarter screens. Okay. Wrist pathology. So I said before, most common wrist fractures are going to be a scaphoid fracture. The most common dislocations of a scaphoid bone, of a carpal bone, is the lunate. Okay. So each of these is pretty unique. And when we do these special tests, you'll be able to have a telltale sign of what's going on. Okay, on the field evaluation, most often what happens is there's scrapes or abrasions that can and do happen. Maybe they've, fallen at a cross-country meet and abrased their wrist and hand, or gotten stepped on, or whatever the case may be. No matter what, we want to make sure we're using universal precautions. We have our gloves on and we're protecting each other. We want to make sure that we're cleaning the area. So if it's something that's not going to require suturing, go ahead and clean it out. And usually we'll put either triple antibiotic or Neosporin on it and kind of cover it and let them go about their sport. Now, if it's something that's going to need suturing, we still want to make sure that we're cleaning them. Most often what I do is I'll clean and then I'll put steri strips on and then have them follow up and go to an urgent care or their doctor where they can get sutures done. I do know that suturing is now going to be one of the things that athletic trainers can do. I have taken a suturing class, but it's not something that I do day in and day out. I wouldn't suture my kids, so I'm not going to practice on somebody else's kids. I would actually, have them refer out and get sutures by somebody who's done it repeatedly and can also give them anesthetics to hopefully alleviate some of that pain that's going on. Okay. These are some of the special tests. This one specifically is the Watson test for scapulolunate instability, where we're pinching right there. Another one you guys have probably seen, and I think I talked about it briefly in 108, where we do the Phalen's test, where this is kind of the telltale sign if you have carpal tunnel. If you're in this position for longer than 30 seconds or so, you will end up having pain and numbness and tingling. Okay. Metacarpal fractures. I really wish I had my old pictures from my cell phone. I had a really cool third metacarpal fracture. It was a spiral fracture. It happened. One of my water polo athletes was swimming and the ball unexpectedly got tossed to her, and while she was swimming, it was a compression fracture. But instead of fracturing anything on the phalanges, it actually was her third metacarpal, and she ended up having to have surgery and have a plate put in to help it heal. and the sutures that this surgeon or whoever closed her up were phenomenal. As far as if you had, this person definitely had OCD. They were the same exact distance apart and same exact length. Everything was pretty, but I guess I geek out on stuff like that. Metacarpal fractures are painful. If this is your dominant hand, it's going to obviously obstruct your ability to be able to do most of the things that you do with your dominant hand. So that's something to take into consideration for them. Finger pathology, we've talked before. The video that the gentleman specifically showed what different boutonniere deformity was and mallet finger for the different tendon ruptures, or if there happens to be an avulsion fracture. So go back and look at the last, I'd say, minute and a half of that video, and that would talk specifically about the different deformities of the fingers. De Quervain syndrome, he did talk about and show us in the video where basically you have your thumb inside your fist and the four fingers go over it and you deviate, and that's the Finkelstein's test, and it's assessing for De Quervain syndrome. And here it is right here. And the last couple of things. On the field assessment. So interphalangeal joint dislocations, it happens so frequently. A lot of times what I like to do is I'll put my body in the way of the person in their hand, and I will pull traction and kind of reduce back into place. Anytime you have a dislocation, you want to refer them for x-rays. And then also splint. A lot of times if they're going back into their sport, I'm just going to buddy splint next to the finger that was dislocated. And then we are definitely going to give them ice and have them send out to get an x-ray. Hand and finger fractures, same thing. We're splinting, we're checking CSM both before and after we splint. If you can't necessarily tell, or if it's maybe the hand, obviously the radial pulse isn't going to do us good because it's not distal. So just check the nail beds and check for a cap refill, and you know that within 2 seconds it should return back to the normal color. Okay, splinting, depending on what the deformity is, we're going to either splint either the DIP or the PIP joint, or potentially in the position that it was found. So this was a shorter one, hopefully shorter and sweet. If you guys have any questions, feel free to shoot me an email or give me a call during regular hours, and I would love to help answer any of your questions that you might have. Thank you, and don't forget to take the quiz by the end of Thursday at midnight.